middle income country. About 75% of those people who have a stroke will end up with some type of motor impairment due to paralysis and weaknesses of the limb. And about 40% of these folks will also have some type of cognitive impairment. We already know lots of the risk factors for stroke, including hypertension and age, growing old. But we also know that HIV now is also considered risk factor. And there are many others that I haven't mentioned specifically here. Context does matter. When we look at this, plot of where what's going on with non-communicable diseases across the world, we see that in sub-Saharan Africa, and specifically in Botswana, there are more people kind of dying between the age of 30 and 70 from NCDs. But in addition to that, there's HIV and communicable disease of HIV has hit that part of the world a lot harder. So now we have a double whammy, if a double burden. And the question is, those are the reasons why we're considering it and these issues in Botswana. What's also at play is the fact that we have a lot of people that are kind of coming down with these types of issues and diseases and being left with impairments. But we still have this huge shortage, and I think this is a worldwide issue, of clinicians and doctors that are able to take care of this population. So what we end up having is this gap in healthcare and gap in rehab care. So because I'm a roboticist, because I'm an engineer, and I've been working in this field for over 25 years, I believe that technology can help bridge this gap. The technology that we're focused on today, I'll talk about as therapy robots and assistive robots. So what are therapy robots? This field is actually quite old. About more than 20 years ago, the folks in the US at the MIT and also where I did my PhD at Stanford began to really think about robots being able to automate and deliver somewhat semi-autonomously therapy for the arm, the leg, the joint. And one of the key things, here's a picture of one of the initial systems that now sells for over 150,000 US dollars, is that they would assess the level of disability and impairment in the limb and be able to give objective measures to clinicians to say what's happening, as well as to support therapy. Typically, they're in the clinics or in supervised settings. There are assistive robots as well, and these function to assist in a variety of activities, telemedicine, helping people exercise, etc. My lab has been involved in this issue for over 20 years. And so we first start looking at these high-end systems that are in my lab. For example, this is the activity of daily living exercise system, and the robot is programmed to support the impaired arm to help people reach and grab and support the recovery of upper extremity function. This is a system that one of my PhD students working on is thinking through a robot that is able to be affordable. It's a mobile system. It has a telepresence platform that would be able to be deployed in rural or in community-based environments to support people with assessment of rehabilitation and clinicians primarily, and to support other people using the system. We also think about the future. You know, if we have intelligent humanoid robot assistants to clinicians and to therapists, what could they look like? So this is a collaboration work that we did with a colleague to develop games and exercise that a system like this humanoid robot could perform with an adult who's elderly. There's enough proof now out there, and I listed a couple of key references here where people have done systematic reviews as to the benefit of robot-assisted therapy. This graph sums it up a bit. If you think about the x-axis as progress over time, we know that in the acute phase after stroke, between 0 and 6 months, if you apply robot-assisted therapy during that time, we see an increase in outcomes for the upper extremity. I'm just focusing on the upper extremity right now. Same could be said in some sense for the lower extremity. And then in the acute phase, where people have applied robot-assisted therapy a lot, there's also the idea that it can also increase functional outcomes. In the US, we could argue that as you look at people moving from the acute to the chronic phase, most of this stuff has technology has been applied with people that don't have any cognitive issues. But there's definitely a lack of a concerted effort with thinking about robot assisted therapy for people that have both motor and cognitive impairment. And our lab has been doing that. And my Kevin will talk more about those issues. So one of the things that's true, if we look at the literature, is when we think about the juxtaposition of motor and cog, where we're really good is at the top level of this graph. And so the current robotic technology is focused on people with high cognitive function and low to moderate impairments, right? And low to moderate function. But there's a lack of effective rehab strategies for people with moderate to low function, but cognitive issues, and then those that really have a lot of cognitive issues. So in this particular area, this is where my lab has been excelling and pressing this issue as to how we can get robots to apply across the platform. So the other question is obvious, is how are robots helping people with stroke-related disabilities in low resource settings? So in stroke in low and middle income countries, and we've done a lot of work in Botswana, Jamaica, Mexico, Costa Rica, we've been really thinking about this issue. We find that many things are similar. The people in many low and middle income countries may have strokes occurring younger. We see that in Botswana, we see that in Malawi, we see that the people tend to be 15 years younger than in the US, for example. We see that there's a higher risk of dying. There's more prevalence of hemorrhagic stroke. The ability to receive specialized rehab care is more diffuse, and sometimes in case very limited to if you live in an urban population. And then there's a lot of a tendency to have lower functional outcomes than because of access issues. Maybe there are lots of really great skilled therapists, but there are not a lot of them. And so they're not available to the large number of people who need help. There's skilled doctors, but there's not a lot of them. So there's low patient doctor ratios and therefore, because of the shortage, low therapist patient ratios. And then the fact that most of this technology is so expensive, we're not able to infuse the technology into these countries where it's direly needed. So I've been working on, with my lab, developing kind of guidelines for how we can creatively think about rehab robotics in low and middle income countries. And I have the things in red is what I'll call out. I think if we're going to do this and we're going to do this well, it needs to be affordable. It needs to have a multi-purpose effort. It can't just be, so right now, maybe our muse is stroke survivors and HIV, but if we put this system out there, it should be usable by anyone with a motor impairment or anyone with a cognitive impairment, as well as motor impairments. They should be effective. We should be able to get objective metrics from them. We should be able to understand the level of disability and also understand how people recover. They should be able to be used in the community, not just in the hospital settings. They should be appropriate for the context that we're in. So if we're in Botswana, how do we make it fit the Botswana, the context in Botswana? If we're in Jamaica, how do we make it fit that context? And we should be a part of capacity building. A problem is when you're introducing robotic technology or high technology, how do we build the engineers that are in country, build them up so that they can support the technology? How do we build up clinicians so that they're familiar with the technology and able to support the use of it as well? So what is affordable? So I go by the World Health Organization concept of what is affordability. They talk about highly cost-effective implementations. And one of the things that I do is that if it's going to be cost-effective, it should be, the cost we should be aiming for is between $1 gross domestic product per capita, the number, versus 3 times that gross GDP per capita. Here's an example. So in the US, we argue that the gross domestic product per capita says that it's an average $53,000. So the idea is that the average person in America earns $53,000 US dollars. Of course, we know that that's not true. There's some people who earn a lot more and some people earn a lot less. So this is the average. And so 3 times that is about 159,000. So i.e. robots that cost $150,000, no brainer. You can do them and they'll be fine. However, when we just juxtapose this against Botswana, 7 times less in terms of the GDP per capita. So deploying a $150,000 robot in doesn't really make sense. So we want to think about how do we limit the cost, but still get the effectiveness of the robot system. And so kind of that's our philosophy. Also, in order for this to be feasible, we have to have partnership. And one of our philosophy is how do we create partners through manufacturing, through healthcare, through the university, through the community, through the hospitals, so that these can be effective. And I think if we can arrange that, I think we have a higher chance of being effective. Here's a case example that we ran in the lab. So we worked with our colleagues in Mexico. We formed a partnership between my lab and a variety of universities, the university in Mexico, and a rehabilitation center in Mexico, which was in an urban location. We worked together to deploy the technology that came out of my lab to our Mexican colleagues. This is one of the first generations of the Theradrive system, and it was then built in Mexico. We then worked with them to deploy this to create what we called a robot gym. And if anyone wants to read about it, here's the reference, where we had 6 workstations, and we then ran, and the 6 workstations have a variety of different types of technology. Then we ran studies where we had 20 stroke survivors. We randomized them to the robot gym, where we had 1 therapist overseeing 6 patients in doing therapy. So it became like a clinic in itself. And then we were able to maximize the therapist's ability to serve more patients. When we ran this study, we had really great outcomes, and you could read about it in the paper. And we saw that the control group and the robotic group had similar outcomes. And in some cases, the robot group outpaced the control group. What does that mean is that it's feasible, and there's a level of trust that you can do with the system. That made us think, how can we take what we did in Mexico and make this more affordable, effective, and accessible? So that led us to think about creating a platform we call the Rehab Cares Gym community based affordable robot exercise system. And it's in a gym. The idea is that this system, if you notice, it's built like almost like a gate platform, that it would house a variety of our robots, maybe this robot or other exercise systems. And then it would allow for example, 1 therapist to be able to oversee 3 patients while they're doing therapy with the system. You could read about that in our paper here. The key, I guess, star of the rehab gym is this Theradrive, Haptic Theradrive system here. And this is an example of a person with stroke and HIV or any person, I think it's maybe a stroke survivor here, working and using the robot to play games while they're using the gym. So the idea that we have is that this is an affordable system. It's more affordable. It doesn't cost thousands of dollars. It's actually highly cost effective in terms of being able to produce this system for under, the GDP per capita of Botswana. And it's firmly in between the GDP per capita and what we argue as 3 times that GDP per capita, closer to the lower end and maybe even lower than that. We would tie the hardware with software that is assessment software and gaming software. And then we would be able to collect metrics that would allow us to measure impairment, measure motor impairment, measure cognitive impairment. And Kevin, my student, will talk more about some efforts that he's done in that particular area. We've tested this system and do see that it helps to improve motor outcomes. And so we feel positive and very encouraged by that system. That actually led us to start thinking, is this feasible in Botswana? The answer for us is yes. When we first went to Botswana, I believe it was 2015, 2016, we met with our colleagues there and we did a lot of touring. We saw the Princess Marina Hospital, we worked with the Botswana UPenn Partnership, and we talked to a ton of therapists. And one of the things we noticed was for 530-bed hospital, there were, at the time that we were there were 7 physical therapists full-time, and then there were 5 occupational therapists to serve both inpatient and outpatient, and that was very tough. And we saw that it was essentially a ton of patients, and what we also saw that a lot of patients said that they couldn't come back for rehab because they lived rurally from the clinic, and so that was a challenge. So there was a cost issue involved, and so the therapy could not be delivered in the frequency that you desire or the World Health Organization outlines, which is 3 times a week for about an hour to 2 hours when you're an inpatient, and at least 3 times a week also when you're outpatient as well. So this was not happening clearly. And space was also a challenge, as some of the therapists reported, as well as equipment. And also many of the therapists told us about training issues, training not easily being available to improve their rehab skills, and then the access to the technology as well. So here's an example of the space that I took pictures that was toured, and we saw that many of these equipments were there, and it actually seeing some of these equipments helped us inspire the form that we chose to put the rehab gym in. And so our vision is that we would create something like this system and we would place it within the hospital environment. And then we would be able to look at the feasibility of this type of system supporting the therapists to be able to meet the needs of their population. Who are the people that we would love to be able to serve? Stroke survivors, and clearly because we're in Botswana and we know that from some studies that have been done that people with HIV also have motor and cognitive impairments. People with stroke also have both motor and cog impairments. So we're looking to basically look at how we can support this example population with the hope of branching off in the future. So my students, Kevin, who will be talking to you, and has won a wonderful award that hopefully, if COVID allows, he'll be able to come to Botswana to do his work. He'll talk next about what he's been doing in terms of assessment and developing assessment tools for people with HIV and stroke. So where are we in Botswana? Is it feasible? I think it is, because we formed a great partnership. So with the University of Penn, my lab, the Center for Global Health, the Center for AIDS Research, that have provided some funding for us to see and test the feasibility of this. We're working with wonderful persons at the University of Botswana, the local co-PI, Dr. Kibetsi, who is at the Faculty of Medicine, along with a variety of colleagues that's also at the Faculty of Engineering, the Botswana UPenn Partnership that is located on the ground there. And then we're also working with doctors that have clinics at Princess Marina Hospital. So by forming this partnership for us, that's hugely important to moving forward. We have a system that we believe is feasible, a robotic system that we believe is feasible, and we have the partners on the ground to try to determine whether this can happen. What are our objectives? We're hoping to develop the therapy robot system rehab cares in Botswana with the Theradrive robot as the star system. We want to test the feasibility of assessing and treating people with HIV and stroke with motor and cognitive impairment with therapists, and the idea of training a cohort of physical therapists or occupational therapists to be able to use the system, and working to support the training of a new generation of engineers who would be rehabilitation sensitive and able to provide or even be the next generation of designers for rehabilitation and for a variety of issues with population. Kind of our timeline in general is that we want to begin in the fall. We want to begin by understanding what's going on in Botswana in terms of rehab, and try to put some exact pen and paper to some of the things that we observed back, several years ago, and determine what's going on now. Things may have improved, and that would be great, but we still think, based on some of our conversations, that there is a need for kind of thinking through these types of technology. And we want to then do usability testing and then a feasibility study at Princess Marina Hospital. So these were some of our key funders, and then I'm gonna stop there and allow my colleague and student, or my PhD student, to talk about the work that he's done. Thank you.
All right, let me just get set up really quickly. Okay. And can I just get confirmation that it's there? All right,
Yes, we can
so
see.
hi everyone. My name is Kevin. I am currently a PhD candidate in bioengineering in the Rehab Robotics Lab. And so thank you everyone for taking the time to be here today. And what I'll be talking about is some of our recent work, which we're currently working on publishing, and approaching this question of whether rehab for people living with HIV is necessary. And I'll be taking more of a rehab robotics perspective on it, but I'll give some background on the clinical evidence to make the case that rehab is warranted in the first place. And so worldwide, over 36 million people live with HIV, and with the advent of antiretroviral therapy, it's become more of a chronic disease. And so we're seeing the HIV population live a lot longer, but with that comes a lot of HIV-associated comorbidities, co-infections, and complications that have become an area of research priority for the National Institutes of Health, and something that we've started to explore in more detail. And so some of the complications that I just want to highlight are neurologic complications, cardiovascular complications, and then premature aging and frailty. And so there have been frameworks that have been put out there for how to approach HIV, disability, and rehabilitation. But even with these frameworks, there isn't really any clear rehab strategies that have emerged as to how best to treat any of the complications that result from aging with HIV. But we know that HIV affects cognitive and motor domains in very specific ways. And so HIV preferentially targets the domains in the brain that are associated with executive function, information processing, attention, and working memory. And there's been a lot of work in developing assessments or looking at this through the lens of HIV-associated neurocognitive disorders, which I'll call HAND from here on out. But we also see impairments in motor skills, so more fine motor skills, gait, coordination, strength, and joint stiffness. And on top of this, people living with HIV experience episodic disability. So these are periods of good health interspersed with periods of disability. And so this adds an added layer of complexity in trying to assess or measure and come up with solutions for rehab. And the prevalence of this is pretty big, where we see in a study that 80% of participants in one study reported at least one impairment, activity limitation, or social participation restriction due to HIV. And this number is a lot higher than what's reported out there in terms of the mild cases of hand, which is anywhere between 50 to 40%. And the mild cases are the ones that are the most prevalent now that we see. And so what does this mean in terms of real world impact? So these specific domains that are affected by HIV are highly involved in activities of daily living. And so these are the things that essentially you need to maintain independence. And these are instrumental to that. So things like managing your medication, doing grocery shopping. You can see that a lot of times it requires an integration of both cognitive and motor skills. And the way that neurocognitive impairment is being assessed right now, where it's focused on purely the cognitive space or just the motor space, may underestimate these impairments. And specifically, we can see this in multitasking. So this is a study that looked at an HIV group compared to a healthy control group. And the HIV group had no impairments on clinical tests, but they started to show these subtle signs of impairment when looking at a multitask that involved a motor component and a cognitive component. And this is notable because multitasking is a little bit more reflective of activities of daily living. And so this strategy is a way to potentially probe those impairments that are a result of HIV and how it ties into activities of daily living. So what all of this highlights is that there's a barrier to rehab strategies for the HIV population. And that kind of centers around the fact that there aren't any quantitative assessment strategies to capture the more subtle impairments. This is kind of not so straightforward when you also include the complications associated with HIV, such as stroke. And this is relevant because HIV is an independent risk factor for stroke. And so we see higher incidence rates and strokes also occurring at an earlier time point. And so as the HIV population continues to age, stroke will become a bigger factor, and then this will also increase the demand for rehab. On top of that, there was a recent study that came out that showed that HIV results in worse stroke recovery outcomes compared to stroke patients without HIV. And so when we're approaching this, thinking about what are the specific rehab strategies for when HIV is present is a really important thing to consider. So rather than thinking about just how do we measure these subtle impairments, I think the reframe is how do we develop these quantitative assessment strategies to capture the range of impairments that we would see across HIV, across stroke, and when they appear together. And so in the Rehab Robotics Lab, we have started to focus on the fact that rehab robotics doesn't really address all the key populations that we would want to benefit. And a lot of the solutions only focused on just motor impairment, and some of these studies even exclude patients with cognitive impairment. And so that means that this group in this bottom quadrant are not necessarily benefiting from that. And like Dr. Johnson mentioned, a lot of the studies are focused in these high resource areas. And so we're ignoring the bulk of the people that experience disability in low and middle income countries. And so for us, I think it's important, or at least in our lab, to think about how to make rehab robotics more accessible because there's this huge shortage of rehab professionals around the world. And this means that people aren't getting the recommended amount of rehab that they need. And our thinking is that rehab robotics can potentially help meet that gap. And so at a basic level, we know about the relationship between HIV and stroke, and we have our expertise in rehab robotics and stroke. And so what we wanted to explore is if rehab robotics applied to the HIV population was feasible. And to boil it down to our driving research questions, we first wanted to know if robot-based measures can distinguish between those with and without moderate executive function and upper limb motor impairments. And we specifically chose that because these are the areas that build on our expertise and that we were seeing as areas targeted by HIV. And then establishing the clinical relevance of these measures, right? So how do they relate to clinical assessments that are being done in the HIV population? And then lastly, how do we use this knowledge to drive the development of better neuro rehab strategies? And so I'll just quickly walk through our methods and how we went about doing this, but these are results, or these are methods from a study that we are conducting here at the University of Pennsylvania. And so far we've had 21 subjects with HIV participate in the study, and we have a subgroup of 6 subjects that have both HIV and stroke. And so you can see that the groups are similar in age, and that's important for us because we wanted to look at the potential effects of aging and like what an older HIV population might look like. And then after that, we conducted a clinical assessment. So for the cognitive domains, we were administered the Montreal Cognitive Assessment, which is commonly administered in the stroke population. And then the International HIV Dementia Scale, color trails, and digit symbol coding are all used in the HIV population to look at various specific cognitive domains. And so we wanted to apply that to see how it relates to the HIV and HIV stroke populations. I'll just mention really quickly that for the MoCA, we also calculated an executive function subscore based off of some of the tasks within that, just to get a sense of their executive function. On the motor side, we conducted the box and blocks test, which measures gross manual dexterity in both limbs, the groove pegboard, which is a more fine motor task, and then grip strength. And so after we collected this clinical data, we had them perform tasks on the robot, and there were 3 different tasks and this is kind of modeled off of the multitasking paradigm that I highlighted earlier on. But for a motor task, it's a trajectory tracking task where the subject plays or uses the robot to follow the task or the trajectory on the screen. And so I'm not sure, the video is not playing for me, but we'll see if it goes. Anyway, on the right is kind of what the raw data looks like, comparing 2 subjects that performed, one that performed well and one that didn't perform quite as well. But we compare how their performance matches to the trajectory that's shown on the screen and calculating kind of a performance error from that. Using a robot also allows us to extract other kinematic metrics, such as velocity, acceleration, smoothness, and the distance that they traveled. And so that was our motor task. For our cognitive task, we used an end-back test that we implemented on the robot. And so the end-back test is adapted from the cognitive neuroscience field, and it measures working memory and working memory capacity. And there's 3 different conditions on this task where there are numbers that are displayed on the screen. And when the condition is met, then they press the button and they get visual feedback, whether they got it right or wrong. And as the conditions progress, it gets progressively harder. And the idea is that if they have a limited cognitive capacity, or if they have working memory impairments, then they have more difficulty doing the 1-back and 2-back tests. Our last task is this joint cognitive motor task that's based off of the Corsi block test. And it's a test for visual spatial working memory and capacity that has an integrated robotic component to it. So each of the tiles are mapped to an angular range on the robot, and then there's a sequence that's shown to the subject, and then they have to remember the sequence and then repeat it by operating the robot. And it adapts to the difficulty by increasing the sequence length if the subject gets it right, and then it decreases if they get it wrong. And this is the plot on the right is just really quickly a histogram of the sequence length counts. So if we see the right subject, or the subject in pink does really well, and that the sequence lengths are longer, and then that's compared against someone who didn't perform quite as well. Yeah, and so everyone performed the tasks with both hands. And what we did was categorize all of the subjects based off of their MoCA executive function subscore and then their box and block scores. And what we saw, which kind of stood out to us, is even before looking at the robot-based tasks, is that there was a high prevalence of gross motor impairment that was present bilaterally. And this is notable. This is just looking within the HIV only group and not looking at the HIV stroke group, is that we saw 7 out of 15 of them had this bilateral impairment. And what the research had been showing up to date was a big focus on the fine motor impairment. And so this was notable for us and stood out. The other thing too is that when we were looking at the subgroups and how and whether the robot-based metrics were able to reflect differences, we saw that each of the tasks were able to do that to different degrees. And so in the NBAC performance, it confirmed that it's able to tap into the executive function and working memory domains. So not a really surprising result, but it means that we can separate between subjects with low cognitive impairment, low motor impairment versus those that have cognitive impairment. For the trajectory tracking task, what's interesting to note is that there was a difference between the group that had low cognitive impairment but moderate motor impairment versus the group that had both moderate cognitive and moderate motor impairment. And this suggests that there is a cognitive component to the trajectory tracking task that, at least to this point, we hadn't really been considering when assessing the stroke population. And so this is something that we'll have to continue to explore. And then lastly, our spatial span task had the most sensitivity in terms of being able to differentiate between the groups. And so when you think about how these robot-based tasks can be applied or implemented, you can either use all 3 of these tasks to get a good sense of what's going on, or really just boil it down to the spatial span task if you are pressed for time or just need a quick assessment. The second thing we looked at was the relationship between the robot-based metrics and clinical scores. And so I'll just quickly walk through the process that we did using the color trails 1 as an example. And so we did a multiple linear regression analysis where we determined the robot-based metrics that were the best predictors, and then plotted the actual clinical score versus the predicted one, and we report the correlation and the adjusted R-squared. And so with the color trails 1, we see a really strong correlation between the actual and predicted scores, and then a strong adjusted R-squared value as well. And we see that as well with color trails 2 and the digit symbol coding score, whereas strong correlation in both cases, and then a moderate effect size for the color trails 2, but a high effect size for the digit symbol coding. And similarly with MoCA EF, but we saw good results across the board in terms of, but the ones to highlight are the color trails, digit symbol coding, and MoCA executive function sub-score. So we also did the same thing with the motor clinical scores. And the big takeaway is that we were able to show a strong relationship between the robot-based metrics and the box and block scores in both the dominant and non-dominant limbs. And so this is just showing the dominant limb results with the box and blocks showing a strong correlation. It's more moderate but significant in the group pegboard. And then we weren't able to really show any relationship with the grip strength. And these results were exactly the same using the non-dominant limbs. And so when we, I guess, look back at the research questions that we initially posited. The first one was, can robot-based measures distinguish between those with and without moderate executive function and upper limb motor impairments? I think for us, the study showed that, at least with this study sample, that we were able to, with all 3 tasks, and the spatial span task showed that it might be the most sensitive to differences. And I think that it's important to look at function rather than clinical diagnosis, because there's such a wide variety of impairments that can manifest in these populations. And then secondly, how do these robot-based measures relate to clinical assessments relevant to the HIV population? We showed really strong relationships between a number of tests in the cognitive and motor domain. And so I think going forward, we can probably boil down some of those tests because there seemed to be some redundancy in the robot-based metrics that predicted them. But this kind of just shows that, yeah, we can do it in the cognitive space, which hadn't really been looked at before, and it's relevant to the HIV population. And then lastly, how can this knowledge drive the development of better neurorehabilitation strategies? I think by identifying robot-based metrics that relate to clinical scores, you can use those as the drivers of rehab strategies, and see, you can anticipate that improvement in one of those metrics will result in an improvement in the clinical scores that you're interested in. But this is a question that we're trying to explore going forward, and as Dr. Johnson mentioned, with a specific interest in Botswana. So I received a fellowship through the International Institute of Education to spend 3 to 5 months in Botswana, which we're now targeting to do in early to mid 2021, to explore how to continue to build off of this study, right, and see how we can apply this method and really further explore how it relates to activities of daily living, because that's not something we've done yet, but is something that would be highly relevant. And so I think with that, I am done with my presentation, but we'll open it up to questions and input and feedback for both Dr. Johnson's presentation and mine. Thank you.
Thank you, guys. Yes.
So let's start the poll again to see if we change 1 or 2.
Well, almost everyone was yes, huh?
We had
that one person, just the one person.
No.
There was one person no. Did we change their mind?
Let's see. Can you see the poll?
Yes. So we want you to answer the poll. Are people answering the poll?
Yes, they are. 1 minute to
Hopefully
answer.
this doesn't go the other way.
Right.
20 seconds left, guys.
Also, put your questions in the Q&A part. I see there's one question. Once the poll's done, we'll begin to answer questions. So if you please put your questions in the Q&A portion.
And the poll. Let's share the results.
So we still have a naysayer. One person says no. I'd be interested in talking to the person who says no, to ask them why. I actually would love to hear why you thought no. So if you're the person who says no, be interesting to let us know what the reason why you say no. So we'll go ahead and begin to answer questions. Please put your questions in the Q&A part. So Dr. Komolafe asked, wanted to find out the attitudes of patients and therapists to robot-assisted rehabilitation. So both Kevin and I can answer that. We've ran, a numerous amounts of patients through our robotic systems. And the bottom line is patients actually really enjoy working with the system. We've had younger patients as well as older patients using the system. They're curious, they're usually open, and really culturally in the US, in Mexico, people are usually excited about using the robots. They are excited about getting therapy. If in a situation where there may not have been access, people are like, oh, you mean something that I can actually use and keep me excited and motivated. So we've not had any patients to say no. From the therapist point of view, I would say it's been most of the therapists, once they understand what we've been doing and they're seeing and we've trained them on the system, we find that their opinions of it increase. So it becomes more positive. Initially, therapists, and to be frank, are always worried, are we in fact replacing them? And I always want to say no. Our goal is not to replace the human. The key is the fact of the shortage and the fact that because the skilled therapists are small in number, but the population are larger in number, our goal is to be able to use the system to help the skilled therapists reach their population. So I think once therapists understand that, they're usually positive and excited to learn new technology, excited to learn metrics that will help them treat their patients better. Kevin, do you want to say anything else?
I'll add that from the patient perspective, the engagement seems to be higher because it feels more like gaming to them. And so we've also explored the gamification aspect of rehab. And so that increases engagement. And with an older population, there may be some resistance to that, but that also lowers kind of the bar for us in terms of the development. Like we don't have to make a super highly developed game, but something that, as long as it's appropriate, will engage them. And I think that will depend on context highly. But also from a therapist perspective, just echoing what Dr. Johnson said, and I think it varies on your context a lot because we're based in an area that is pretty well staffed, right? And so their views may be a little bit different than someone who sees firsthand like the shortage or are just overwhelmed by the need.
So the next question that was is, what are the challenges associated with the setup and running of the robotic system? So I think once we've trained, then I think the setup and challenges decrease. I would say initially, because it can be somewhat of an experimental system, there may be some challenges in kind of keeping things consistent. But I think in general, learning and creating a system from an engineering standpoint or from a technician standpoint, I think we've taught a lot of different people how to run our system, from Jamaica to Mexico. And we have some long distance supported the systems as well. But I'll let also Kevin answer that, because he's the student, he's running every day working on the therapy system, so he might have a different point of view. Go ahead, Kevin.
I think that we've encountered challenges because we're not necessarily always there in person, but I think we've always had the engineering support, and I think that making sure that we have the documentation and kind of like stateside support is important. But we've never encountered yet a situation where it just wasn't appropriate. Where I think, yeah, having the engineering support is helpful, or is necessary, but it doesn't require like an expert, like a high level expert to be able to operate. And that's what we're trying to approach the design of, right? That we can provide a platform for that. Yeah.
Something to piggyback on is, one of the things that we, from a capacity building standpoint, is to teach engineers and rehab people who want to kind of use their engineering skills in the medical and the rehabilitation spaces, how we've done stuff and how to develop even gaming that would be appropriate in the Botswana context. And one of the things we hope to do is maybe with the Faculty of Engineering is to run some type of hackathon where we could develop games that are kind of more appropriate for the Botswana context that we could use with our systems as well. So I think that's part of the collaboration with the Faculty of Engineering. There was a question about the benefits to the participants, I guess, and are there any anticipated risks? Great question. There are, the benefits can be, I would say the two big areas. One is when we do intervention with the system, the benefit can be improvement in function and ability. Initially, when we're looking at assessment, the benefit's more to the clinician, because when we think about assessing patients, what we have done is provided a tool that allows clinicians to do a better job assessing levels of function. So the participant as the clinician, there is a huge benefit. As a patient, the benefits will come in terms of hope, as in now you have an opportunity to have more time to do therapy where your clinician can program the system, let you get started and work with another person while you're actually doing therapy. So that is the potential benefits. Are there any anticipated risks? Great question. From a lot of the studies that have done on robot-assisted therapy, the adverse events that occur have been relatively minimal. And if anything, people have complained of soreness and of the standard things that happen when you exercise. So if you haven't been exercising a lot and you go out there and run a mile, you're gonna have soreness in your muscles and some discomfort. So those are the main anticipated risks that have been seen from many clinical trials. And from our work with patients, it's the same. One of the things though, if a patient is complaining about pain before they get on the system, you may want to say, hey, you may need to rest. The same thing that you would do to a patient if you're running them in your clinic. Any thoughts, Kevin?
I don't think so. I think that hit on all of it. Yeah.
So the other question was asked is, you highlighted capacity building as a way of capacitating the local engineers to use the system. How long trainings last for someone to be able to effectively use the system? Great question. I think this is a part of the capacity building is education. Like we decided to engage in these series of seminars to begin to educate both engineers and clinicians about what's going on. And once we sit down with you and train you, you have to also get used to the technology. So I can't say it's going to take a month or it's going to take 2 months, etc. But we can get you up to speed probably in a day, but you'll need to be using the system to get, more fluid on it. So we think over time, a part of it is educating young engineers about some of the challenges of rehabilitation, engineering, and design. I teach a course at University of Penn in a semester, and where I talk about these issues of designing technology for people with impairment and some of the challenges. So hopefully I have a Fulbright that will allow me to come to Botswana at some point. So hopefully we could do along with the Faculty of Medicine and Engineering, a short workshop or training seminar on these issues to bring engineers up to speed and clinicians up to speed as well. It was
Can I add something really quickly?
Yeah, go ahead.
I'll just add really quickly is that I think capacity building doesn't have to be with respect to the system specifically, and is that we can engage in other efforts to do that. I think Dr. Johnson also taught a class where we went to Jamaica and we worked with students there, and they teamed up with students at Penn, and being able to kind of have that cross-country collaboration and the knowledge of the local context is really important as well. And so I think that we can get creative around it as in terms of how to build capacity, but it's not specific to the system that we're trying to.
Yeah, that's true. And it's also, I think a good thing is to think about, it's a philosophy of bringing technology to bear. There are two more questions that we want to get to before the end of our seminar. The first question asked, when you come to Botswana in 2021, like in the spring and the fall, are you going to start first implementation at the hospital or will you go straight to the community? Great question. So in fact, actually what we'll probably start is we have to develop the system and transfer our robot technology to UB. And so some of the aspects of the system are kind of already developed. It's kind of getting the training done. So we anticipate that we'll first be at the University of Botswana doing some, development and testing and kind of validation there. Then I would say the next step would be PMH, is to find a location in Princess Marina where we can locate the robot system and create this clinic or this robot gym area so that we can test it within the hospital. I think the last part is in the community, because I think we want to first prove that, the system is useful within probably one of the inpatient or outpatient spaces in the Marina Hospital. And then we hope that once the next step then could be a partnership that moves it into the community. So that's kind of where we're hoping there. The follow-up question that someone asked was, do you already have a space in Princess Marina where this setup will be done? So initially we'll be at our development space will be in the University of Botswana. And when we get there and we begin to kind of move forward, we have talked to Princess Marina Hospital before, when we initially came, and there was willingness to host the system. Clearly, time has passed, so it's about finding where would be the right spot for it once we are ready to move it into the hospital, and that would be a discussion with the powers that be, respectfully at the hospital in order to determine those issues. So there is a last question before we have to go. Is there an age limit to the participants who can partake in this, as it will be suitable for a 70-year-old or 25? We've tested people anywhere from stroke from 18 and up. So I would say most of the part we've usually have, I think the oldest person we've tested, I've tested maybe someone in their like 75, 80. However, that's not typical. But we have tested young people as well as older people. If there is a need and you have a stroke and there is an opportunity and you're interested in being a part of it, we're probably going to keep the limit somewhere around 85, but really everyone could use the system. That we should probably wrap up, because to be sensitive to time, it's now noon. I thank everyone for participating in with the talk. So Nini, do you have anything to say, or Kevin?
Please go ahead, Kevin.
Oh, really quickly, I just dropped my email in case anyone wants to follow up, but it seems like there are a decent number of people who are based in Botswana, and so really happy to connect and figure out more, because we're starting to get to the stage of really implementing the studies. And so figuring out really the nitty-gritty details of how we're actually going to do that and establishing even more connections will be super helpful. So thanks again for everyone who tuned in.
So we'd like to thank you everyone to attend this webinar. You will receive a follow-up email with a survey that will help us to shape our next webinar. So please answer it. It will be really good for us. So thank you, everyone. And we hope to see you again in our next webinar. Bye-bye, guys.
Bye-bye. Next month. See you next month. Take care.